Great, so thank you. This is my favourite conference in the whole world, and it is such a privilege to actually be talking to you behind the podium, so thank you for this, because it's a great privilege. So, a bit of audience participation. What's the prevalence of dementia in the population? Just someone shout something out. The percentage of the population, let's say the UK population, have got dementia. It's about 1%. In the over 65s? 7%. Okay, so functional cognitive symptoms are much more common than dementia. It's a very, very important principle. This data is 20 years old, and these are kind of base rates of functional type symptoms in healthy young people, but I'm sure all of you in this room at some point have had one or more of these symptoms. So the starting point for cognitive symptoms is that they are always more likely to be functional than organic. Okay, that's just an important sort of epidemiological reality. And then when people get as far as the memory clinic, we know that if you are under 65, you're really quite unlikely, even if you get as far as being referred by your GP into the memory service, you're quite unlikely to get a dementia diagnosis. So this is data based on about 5,000 people who went through English memory services in 2019, when we did this big national audit. And you can see that if you're age 65 and over and your GP refers you to a memory service, it's quite bad news. You've got a 2/3 likelihood of being diagnosed with dementia, and then the rest is kind of MCI and some other stuff. But if you're under 65, it's the other way around. Most young people in memory services don't have dementia. And if we look again at that, break that down a little bit more and see what people do get diagnosed with, and what we've done here is divided this into everyone aged over 65 on the right, everyone aged under 65 in the middle, and then just those aged under 55 at the far left. And you can see, as you'd probably expect, as people get younger in memory services, the likelihood of dementia goes down. The likelihood of MCI stays about the same, but I suspect that a lot of that MCI is mislabeled, and we'll come back to that later. You can see that primary psychiatric diagnoses get more common. Functional cognitive disorder gets more common, but almost certainly is underlabeled in memory services because a very large number of people, young people, in memory services are getting no diagnosis or some other sort of non-specific type diagnosis. So there's definitely a problem. I also don't believe that even in patients aged over 65, that the prevalence of FCD is 1 in 1,000. I don't believe that. So there's something around this concept that Veronica has so eloquently set out for you is still not widely accepted within the dementia community, and yet it is everywhere. Now, let's talk a bit about this is data from community memory services, so psychiatry-led community memory services. But let's come to a cognitive neurology clinic. So this is our cognitive neurology clinic at St George's, and this is an audit that Arthur Stacey, who was a resident doctor with us, did recently. And so he looked at all our referrals from a 6-month period from October 24 to April 25. And we got nearly 300 referrals in that period of time. And you can see that our referral base is a bit different from a community memory service. So a typical age at referral to a community memory service is 79. That's the median age. So we're about nearly 20 years younger than that. And we get our referrals from a mixture of GPs and other specialists. So this is the referral base. Now, this is about triage. So what happens when we triage, and I do most of the triage in the service, so I take responsibility. If anyone wants to disagree with what we've done here, I'll take responsibility for this. So 2/3 of people who get referred to us, we see them. About 8% are redirected internally, so we say, well, that should really go to movement disorders or headache or whatever it is, or general neurology, and then we reject about nearly 1 in 3 referrals. And of those rejections, there are various reasons why we might decline to see a patient, but the commonest is that we think this person has likely functional cognitive disorder. Now, it's not that no one with functional cognitive disorder gets into our service, it's that if we can identify it from the referral letter, and there are a number of features of an essentially kind of mild and benign presentation, which I'll show you in a minute, we believe that can be managed in primary care with advice and guidance from us. There are other reasons why we might decline to see people, but that's not the focus of the talk. So let's look at the people that we turned away because we thought they might have functional cognitive disorder. So their median age was 49, so they're even younger than the median age of our general referral base. And these are the criteria that I have sort of developed informally, that then when Arthur did the audit, he tested, well, are you actually consistent in practice? So my view is, that if the person is presented alone to the GP and not brought an informant with them who is expressing concern about the symptoms, then that is unlikely to be dementia and likely to be functional. If there is no evidence that that person is declining in activities of daily living, for example, because most of these people are working age, if they're still working and no one at work they're not on performance measures at work, that is very unlikely to be an organic cognitive syndrome. And if the GP has administered a cognitive test and they've performed normally, or they've not administered a cognitive test, in other words, there's no evidence of underperformance on a cognitive test, that is unlikely to be an organic syndrome. And especially if they're young, because age is an important biological variable in the likelihood of things being functional versus organic in the cognitive context. So if this is the picture, then I will say, I think that's likely to be functional. I think it's quite benign on the basis of all of this. I think that can be managed in primary care. And 75% of the people that I basically rejected from the clinic met those criteria. And then what Arthur did is he followed them up, looking across the record to see what came of them. And what happened was that in 30 of those 41, after a reasonably short follow-up period, there's no evidence of them re-entering secondary healthcare. So things have been contained in primary care on the basis of the advice that we gave. 3 were referred back into our clinic, and we did see them, and all of them, as you can see, had an essentially functional or psychiatric diagnosis. So we were right there. And then of 8 were eventually had been seen or were seen somewhere else. And I'm not going to go through the list in the interest of time, but you can see that all of these people have either a functional cognitive disorder or they have a primary psychiatric diagnosis. So we didn't miss anyone. And this is quite interesting because actually if you look at NICE guidance, there's already some guidance on referrals. Now I've got a few issues with this, which I will point out, but I'm not doing anything here that's really very different from the direction of travel set out by NICE in this guideline about what GPs should do with people with suspected neurological symptoms, or neurological symptoms due to suspected underlying neurological disorders. So what's clear here is that if you're under 50 and you have memory problems with no signs, don't refer if memory function is normal. And symptoms are consistent with what NICE calls concentration difficulties. Now, I have a problem with that because what we showed in our paper, which Tiago Teodoro, who's in the audience, led on, is that actually the concentration in people with functional cognitive disorder is normal. It's objectively normal. So I think this language we need to revise. But essentially, there's already sort of prior art saying that we recognise that there are a lot of younger people with subjective memory symptoms and other cognitive symptoms are functional. And there's also this thing here, which is about the context, cognitive symptoms in the context of somatoform disorders like CFS/ME, chronic pain, fibromyalgia, and already suggesting that we recognise that the memory symptoms in those patients don't require the initiation of a new pathway through neurology, because they're a core part of that disorder, and we showed that in our previous paper. Now, let's have a think about what we know about let's just dig in a little bit into the phenotype of people with functional cognitive disorder. And this is based, again, on the paper that Tiago was the first author on. And we learned quite a lot, I think, just in a relatively small sample about FCD, at least in our service. So this was our cohort that we studied, and you can see that they are average age is about 50. And you can just see there the sort of the baseline, okay, in terms of their baseline characteristics. But what I really want to show you is a little bit about how they rate their memory compared to healthy controls. So HC is the healthy controls who are age matched, and then a little bit about some other characteristics. So if you look here about how people rate their memory when they've got functional cognitive disorder, there is essentially no overlap between how people with functional cognitive disorder rate their memory and the healthy population. So there's a profound separation between these two groups. So this shows you that this research cohort that we are looking at consists of people who genuinely have a very, very poor subjective experience of their memory. And this is probably the most important slide and the most important thing that I think that we found in this paper, which was a very elaborate and sophisticated experiment that Tiago ran looking at various aspects of cognitive function. But actually, it was in the baseline data that I looked at this and my eyes popped out when I saw this. Because if you look at these two groups, healthy controls and our functional patients, they are really very different in terms of their mood state and on a whole range of other sort of neuropsychiatric measures. And by the way, if you look at the depression scores, we actually capped this at 14. So anyone who had a PHQ-9 of 14 or above was actually excluded from this study. And despite that, these are people who have non-overlapping depression scores, virtually non-overlapping anxiety scores, and they rate high on fatigue, pain, sleep disturbance, likelihood to dissociate, and obsessiveness. So really quite a kind of neuropsychiatrically complex group of people. And then, if you look across the three major UK cohorts that have published work, so this is Norman's FCD, ACT for FCD study, this is our cohort, and this is the UCL cohort. Jonathan Hutley, who might be in the audience, was an author on this. And what you see is there's quite a lot of consistency between these cohorts, admittedly research cohorts, between their depression and anxiety scores. These people are all moderately depressed and quite anxious. That seems to be a trait that's consistent across cohorts. Now, I think coming back to neurology, so one of the things that I and Veronica already showed this, try and teach neurologists, is to think in a formulatory way about their FCD patients and to think about predisposing, precipitating, and perpetuating factors. And I've just put some of the ones that I have come up with over the years on here, and this changes over time. We change this in response to as we discover more. So, for example, the relationship between autism spectrum condition and functional disorders is a very sort of live and evolving area. I think a relative developing dementia is really quite an interesting precipitating factor. But lots of things on here, and there's one in particular on there that I'm going to come back to in a minute. Now, I've decided to be deliberately provocative and disagree with Veronica on one thing, and I hesitate to disagree with Veronica on anything, and it's going to involve, I'm afraid, Alan, I'm going to do something to you on your birthday that which is not a very kind gift, so I apologise for this. So Alan published this paper about 10 or 11 years ago now, in which he set out a kind of taxonomy of functional cognitive disorder, saying, look, we can divide it up into five different categories. Now, my view is that actually, and to paraphrase a disgraced English former politician, I am a lumper, not a splitter. I think that, I'll explain that later if anyone wants to know the reference. I actually think that it's really one thing. Because I think on the basis of some of the data I've showed you, I don't think that we do see isolated functional cognitive symptoms. I think that people with cognitive symptoms are part of a multi-dimensional disorder in which pretty much everyone has some kind of evidence of other systemic involvement, so pain, fatigue, other things. I think that anxiety and depression in the context of FCD, I think it's part of it, right? These people, they pretty much all have detectable levels of mood disturbance. Health anxiety about dementia is not a separate category. I think it's one of the features that it can be a precipitating factor for FCD. And this thing about normal cognitive lapses that become the focus of attention or anxiety, I think that's a core symptom of FCD. So I think these things all belong together. And this reminds me, this whole thing about this being part of it, that about 10 years ago, when we were starting to evolve the FCD concept, and I presented one of my first talks about this, and Mike Copeland, who's in the audience today, he said to me, I'm not sure I believe in this FCD concept. I think what it is that these patients have all got a mood disorder, and you neurologists are just not good enough at detecting psychiatric symptoms to diagnose it. And the thing is, Mike, if you hang around long enough, you're right. Okay, so I think there is a lot of this, and we need to name it. So does any of this matter? So one of the things I'm going to show you is that something is going wrong in primary care in England. This is now with my National Clinical Director hat on, which I wasn't otherwise planning to wear today. But there is something going wrong with misdiagnosis of mild cognitive impairment in women in their 40s and 50s in England. I'll show you that data in a minute. And that is because people in primary care and elsewhere do not understand about functional cognitive disorder. And if you label people with MCI, which is a pre-dementia diagnosis, that is only going to be associated with very significant iatrogenic harm. And the failure to recognise mood symptoms in patients with functional cognitive symptoms is a missed opportunity for treatment. Referral of patients with functional symptoms to memory services delays access for those with a plausible likelihood of dementia. At the moment, 53% of people in England are waiting more than 18 weeks for a diagnosis of dementia from the point of referral, which is unacceptable. And so we need to make sure that the right people are in dementia diagnosis services, and people who've got functional disorders are being appropriately diagnosed and treated somewhere else. And I will also say, I'm not going to show any data on this, but one of the things that alarms me slightly, and Veronica's seen evidence of this in Portugal when she's spoken to cognitive clinics, is that there seems to be an assumption that all we need to do in any one of the memory symptom is just do a p-tau217 blood test, and that will sort it out. Okay? And I think that again, is because of false positives, it can result in significant iatrogenic harm, and it's the wrong test. Because the test in FCD is not do they have neurodegeneration or not, it's why do they have symptoms. It's this. It's the formulation. It's trying to work out why is this person suffering? Why are they here? What can we do to help them? Okay, so, and this slide is like...
I've got to give you the 1 minute.
1 minute, okay, now it's my last actual slide before my conclusion. So on this slide, if you look at this, it's a slightly messy slide, but I'll just try and point it out to you. So on this slide, women are purple and men are green, which, as we all know, is a biological fact. And and everything that's slightly dark is December 2025, and everything that's a little bit lighter is the situation exactly a year ago, in December 2024. And what you can see here is that in the space of a year, the number of women in their 40s and 50s with mild cognitive impairment in England has absolutely skyrocketed, such that there are now as many women in their 40s and 50s with an MCI label as in their 60s. I mean, this is astonishing, right? This is misdiagnosis on a massive scale. Okay? And this is because people are coming in with brain fog or other cognitive symptoms in midlife and are being mislabeled, right? So we have a problem. We have work to do. Right, so to conclude, most subjective cognitive symptoms are functional, and I think this should be the starting point in any age group with a low pretest probability of dementia, and probably stroke possibly in older people as well. That's more controversial. Recognise the classical presentation, a high burden of subjective but inconsistent, that's all the FND thing, inconsistent memory or language complaints, not endorsed by an informant, and without a commensurate decline in activities of daily living. And in our cognitive neurology service, about 15% of referrals can be identified as likely functional based on simple triaging rules and managed in primary care with advice and guidance, as already sort of approved by NICE. And administering a cognitive instrument or a biomarker in this population isn't helpful. It's the wrong test. If you want to do something, do a PHQ-9 or just ask the patient about their mood. Use a personalised formulation-based approach. That will have face validity for the patient because you're asking them, it's individualised. You're asking people about how things are for them and why you think they, at this moment in their lives, have developed symptoms. Keep it simple. I don't actually think we yet have evidence for FCD subtypes, but obviously from research that Veronica and others are doing, we will learn that in future. And bear in mind, importantly, that FCD is not an isolated disorder. It's significantly comorbid with depression, anxiety, fatigue and pain. Be prepared to name these contributors and treat or signpost for them. Thank you.